Hello, everyone. We're here today with GU Oncology Now with the ASCO Bladder Roundtable discussion. My name is Vadim Koshkin. I'm a GU medical oncologist at the University of California, San Francisco, where I help co-lead the bladder cancer program for the medical oncology side. And we have a great panel with us here today, and I'll let the panelists introduce themselves, starting with Matt.
Hi, I'm Matt Zibelman. I'm an associate professor of GU medical oncology at Fox Chase Cancer Center in Philadelphia and director of clinical research of the GU service line.
Hello, my name is Cora Sternberg, and I'm a genitourinary oncologist and professor of medicine at Weill Cornell Medicine. I'm also the clinical director of the Englander Institute for Precision Medicine at Weill Cornell. Happy to be here.
Hi, I'm Dr. Dan Petrylak. I'm professor of medicine and urology at the Smilow Cancer Center, Yale University, and happy to be here as well.
Great. Well, again, a wonderful panel here, and our topic here today is really the treatment strategies for advanced bladder cancer. One other point I wanted to touch on is, and actually something we briefly discussed, which is that increasingly some of the drugs we're using in the metastatic space are moving earlier in the perioperative space, adjuvant nivolumab being a key one. How does that affect your subsequent treatment decisions? Would you, for instance, consider enfortumab pembrolizumab combination for someone who previously progressed on adjuvant nivo? Would you not use a checkpoint inhibitor again? How do you guys?
Nobody knows what to do. I'm definitely giving an adjuvant nivolumab, and if they progress right away, I probably give them EV alone. I don't give them EV plus pembro. That's what I've been doing in those patients, because if they progress like on their first scan after they just finished 17 cycles or whatever, how many cycles, actually it's 1 year, but
We've created a new population and we have no data, so I think it's hard to know. I think the timing of when they progress is definitely really important. Did they get neoadjuvant chemotherapy or not, and have they had that? How long benefit do they have, or if none at all? So I think that all factors in. We don't know in urothelial cancer the benefit of continuing immunotherapy. If we extrapolate from CONTACT-3 in kidney cancer that we're going to see, there doesn't appear to be a benefit in kidney cancer patients for continuing the immune checkpoint inhibitor. If I had to bet, I would suspect it will be the same in urothelial carcinoma, and I think that will be true, but we don't know.
The only data we have is the Joran study with 1 year of nivolumab adjuvant. So I stop at 1 year and then I rescan.
But to your point about, do you do EV alone, or would you continue with EV pembro, for example? And I think it's hard to justify continuing EV pembro in those patitions, but we really don't know.
Retreating with
or retreating.
The other way of looking at that is what's the downside of giving the pembro? And is there much of a downside of more toxicity giving it later on again? And certainly, if you believe that there is synergy, true synergy between the two, then it's justified doing so. But if you are concerned about toxicity and cost, then single agent is the appropriate thing.
I'll go on the ledge and say I'm concerned about toxicity and cost, and I'm not a true believer in synergy at this point. I think we've seen a lot of additivity and not a lot of synergy, but I don't think we really know for sure.
Even with EV pembro?
Even with EV pembro. I'm remain unconvinced that there's true synergy, but I think it's hard to prove that, and I don't think we really know.
I've seen absolutely wonderful responses with EV pembro in patients who are cisplatin ineligible, giving that first line. But once I've given adjuvant nivolumab for a year, I just can't justify giving an immunotherapy again right afterwards.
Mm-hmm. And also remember too that the definition of second-line therapy was arbitrary. It was a bunch of people, docs getting in the back room and basically saying 1 year is our cutoff point. Yeah. And there's no biological reason behind that.
Yep. That's a great point. Yeah, if maybe those patients are retreated with even checkpoint inhibitor monotherapy, they would still do well. Right?
Maybe with time, but not right away.
But if Cora alluded to this before, even looking back at when we were thinking about giving MVAC again, there was a lot of, the red herring at that time was a trial that was done that gave intense MVAC to patients who had failed prior MVAC. And when you looked at that data, there were responses in it, but the responses we were seeing were more than 18 months out after the original treatment with MVAC. So, when do you lose that resistance mechanism? We really don't know. And of course, it may be completely different immune therapy.
Well, again, I think this highlights what an exciting space this is right now with, many available options that weren't available even a few years ago, and how, as you mentioned, we're actually creating new patient populations where we're not quite sure what to do because of the many options that we have.